Hey, Dr. Sheehan, how are you?
I'm well. How's everyone doing?
Doing okay. Randy's going to be on in about 2 or 3 minutes. He's just running a little late. I'm just getting things set up here, and we can have Dr. Raza want to load up his slides to share a view.
Yep.
Thanks for joining us.
Hey, thanks for having me.
Our pleasure.
Let's see here.
So I will say what Randy, I think, usually says, which is we typically stream this and all on YouTube, and also have some live participants watching, and then it goes as well to Instagram and through the Lenox account, I believe. And then so there's a good bit of people that will be watching this, and we'll just go through your slides and then have a little bit of a discussion afterwards. We try to limit the discussion to about 30 minutes to keep things lively and not overwhelming.
Okay.
Hey everyone, how we doing?
Hey Randy.
Hey Randy.
Sorry for the delay.
I was trying to fill in for you, but I'm glad you're here.
Are we at 4? Did I make it? Oh, right
on.
Yeah,
we're live on YouTube right now. We can start going.
Great. All right, well, welcome everyone. Welcome back to Tumor Talk. Today we have a very special guest, Dr. Raza, coming from MD Anderson Cancer Center. And, usually I give a whole spiel about the collaborative effort. The big thing is that this was something, pioneered by the Journal of Neuro-Oncology in association with Lenox Hill Neurosurgery. And we're kind of highlight papers and research that have been published in the JNO. And, in particular, we wanted to reach out to Dr. Raza after this really review of advances in the management of sarcomas of the skull base. This is part of our series that are sponsored. Actually, I want to make sure I say that this is sponsored by Stryker. And so we appreciate their educational donation to us in the NREF. And so without any further ado, Dr. Raza, please take it away. Welcome.
Thanks, Randy. And thanks, Jason and Nitesh and the journal for including me. The journal had a special issue recently looking at skull-based malignancies in general. And as part of that, what I was asked to do is review, sort of the overall management of bony sarcomas of the skull base. And in that process, really sort of reviewed our own experience at MD Anderson. So that's a lot of the data and the figures you see in the manuscript, and presenting this on behalf of my co-authors Adara Adem and my partner Franco De Monte. And the bony sarcomas are really sort of a basket category of diagnoses. And when you look at our own practice here, chordomas, chondrosarcs, and osteosarcomas account for about 90% of the bony skull-based sarcomas that we treat in the skull base. And a lot of what we know about these diseases really come from the orthopedic and spinal oncology literature. And because of the perceived inability to get an en-bloc resection, and because some of the challenges of delivering high doses of radiation therapy to these larger tumors in the skull base, traditionally there's been a lot of skepticism and pessimism about the long-term outcomes for bony sarcomas in the skull base. And that really was sort of the premise for this manuscript, is that historically we've had a very poor outlook on this disease process. But when you look at our own sort of institutional experience, we're starting to see incremental improvements in survival and tumor control rates. And really in the article, what we do is sort of cover some of those advances that have occurred, not only with regards to surgery, but also pathology, multimodality treatment, systemic therapy, and radiation therapy that are resulting in these incremental advances. And that's sort of what we briefly go through the manuscript. And the first big area of advancement in this disease process is really pathology. For example, traditionally chondrosarcomas have appeared the same as chordomas, and even some forms of osteosarcomas underneath the manuscript, under the microscope. But with, for example, identification of brachyury, for example, being pathognomic to chordoma, the pathologists are now able to make much more accurate diagnoses. And you can see the implications of that. For example, when we look at our sarcomas, they really behave across a spectrum with regards to progression-free survival and overall disease-specific survival, where high-grade osteosarcomas traditionally have had the poorest survival, are also at highest risk, not only for local recurrence, but also distant metastases. And on the other end of the spectrum, you have giant cell tumors. So again, having key and accurate pathologic diagnosis was a key advancement in the management of this area. And then traditionally, we've referred to, for example, chordoma and chondrosarcoma as a single disease process, but as we study the histologic subtypes, we know that they also behave across the spectrum. So look at chordoma, for example. We know that the dedifferentiated type chordomas again, have the poorest survival, highest risk of metastatic disease. And so the point of this slide is that we are developing a better understanding of the biologic behavior of each one of these diagnoses. And these differences in survival and metastatic risk really drive the indications for chemo and radiation therapy around the time of surgery for these individual diseases. So, again, we review, for example, our chondrosarcoma experience in this manuscript. And traditionally, we have thought of chondrosarcoma as a locally aggressive disease process where it was just surgery, and maybe radiation therapy. And what we know is that is not necessarily the case. These come in 3 different histologic subtypes. The conventional chondrosarcomas are the ones that I think we really think of where their risk of recurrence is only local. And that's why we really rely on surgery with the selective use of radiation therapy, depending on the extent of resection and histologic grade. On the other hand, mesenchymal and dedifferentiated chondrosarcomas, with our better understanding of this disease process and accurate diagnoses, we know that these patients are at high risk for developing metastatic disease within a short time of diagnosis. And as I'll show you with advancements in systemic therapy, our thought process for treating these tumors is that we always begin with preoperative chemotherapy, then proceed to surgery, and then adjuvant chemoradiation therapy, because these aren't locally invasive processes. These patients typically die of metastatic disease. And so along with histology, the ability to tailor treatment to each individual histology and the risk of survival and metastasis has sort of been another big advancement in this area. Now, traditionally, the only chemotherapy agents that were available were really the traditional platinum-based chemotherapies for bony sarcomas. And we've seen with the development of targeted therapy options and even immunotherapy options that the use of systemic therapy is growing in the management of this disease process. Traditionally, we used to rely on, for example, platinum-based agents for high-grade osteosarcomas to reduce the risk of metastatic disease. But for example, look at giant cell tumor. This was traditionally thought as purely a surgical disease process. But with the introduction of denosumab, we can take an anatomically extensive giant cell tumor like this one that I had treated, involving the low clivus, the entire temporal bone with encasement of the internal jugular vein, lower cranial nerves, and the carotid artery. And with subsequent treatments of denosumab, you can see over time from the top left down to the bottom right, a significant anatomic response, and that makes surgery much more favorable in this situation when we pursue it as opposed to the top left. So, the changing landscape of systemic therapy is allowing us to rethink what the expectations are in the management of some of these anatomically challenging tumors. Then from the surgery standpoint, traditionally we used to be happy with just an intralesional curettage of these lesions. But again, when you look in the spinal oncology and the orthopedic oncology literature, the gold standard is an en bloc resection. Now, while we can't do that in the skull base, we know that we can certainly achieve an anatomic resection of each compartment of the tumor. And so for a petroclavicle chondrosarcoma like this, with the full spectrum of open and endoscopic approaches, what we can do is drill out all the invaded midclivus, all the invaded petrous portion of the temporal bone to anatomic landmarks where the carotid artery skeletonized, where the dura skeletonized, and then the subdural disease extension of this tumor can then be resected. So while we can't get an en bloc resection, we know that when surgery is done in a systematic and anatomic fashion like this, and looking at our own experience, what we know is that we can significantly impact tumor control rates for chondrosarcomas, for chordomas, and even survival for high-grade osteosarcomas. So the skepticism that used to come from our orthopedic and spinal oncology colleagues that, listen, you're not doing an en bloc resection, so what's the point of surgery? I think with the neurosurgical techniques and the full plate of skull-based techniques, that is no longer as a concern. And clearly this data shows that we're making an impact on this disease process. And, certainly these bony sarcomas, whether you're looking at chondrosarcs, high-grade osteosarcs, they occur at all sites of the skull base. And the acknowledgement that each anatomic site in the skull base has its own challenges with regards to access, resection, and reconstruction has always been an issue. And for each one of these anatomic sites, whether zone 1 or anterior skull base / clivus, zone 2, the infratemporal fossa, and zone 3, true temporal bone malignancies like this high-grade chondrosarc, there have been significant surgical advancements that we review in the manuscript that have improved our expectations for some of these challenging tumors. And when we look at the distribution, again, reviewed in the manuscript, nearly a third of these patients will involve multiple anatomic zones. And so these tend to be multi-compartmental tumors where subtotal resection was the norm, but that really isn't the case. So this is an example of a low clival craniocervical junction chordoma that we include in the manuscript. And the challenge, whether you do this open or endoscopic, was the ability to get a gross total resection of this. And, with an endoscopic approach where the carotid artery is skeletonized and, a nasopharyngectomy is done, the entire clivus, the entire hypoglossal canal can be skeletonized, and you can get a complete resection. And for reference here, the arrow here is on the upper cervical carotid artery. So the advancements in surgical technique, whether it's endoscopic or open, have helped redefine expectations for clival pathology. And when you look at the anterolateral skull base and temporal bone malignancies, this is an example of a mesenchymal chondrosarcoma that we included in the manuscript. Here you can see the images on the left. And certainly the ability to resect this was described a long time ago. The subtemporal infratemporal fossa approach, or the FISH approaches, were described decades ago. One of the limitations in tackling a large malignancy like this was not only with regards to access and achieving margins, but as reconstruction. You have a high volume defect where the entire anterolateral skull base is gone, the ear canal perhaps sacrificed, the mandible resected, and it's advancements in plastic surgery with basically refining the ability to do free tissue transfer that has helped redefine surgical complications for this patient population. And now with using, for example, an anterolateral thigh flap, all of this area can be reconstructed. Our plastic surgeons now have a much more systematic approach in terms of not only reconstructing high volume defects, but reconstructing defects where you end up in the oropharynx and nasopharynx, in the previously radiated setting where reconstruction options used to be limited. And then even with regards to the need for facial nerve reconstruction, those advancements have occurred too. And so the advancements in reconstruction and parallel skull-based surgery, again, have not only enhanced our ability to achieve negative margins, but to also minimize the morbidity that some of our patients used to face. Now, along with surgery, we've seen a lot of advancements with regards to radiation therapy. And this goes outside of, whether you decide to do SRS, photon-based, proton-based, or carbon ion techniques. Within each one of those modalities, I think a lot of people will attest to is that the conformality has improved. So when proton beam was first introduced, even here at MD Anderson, the radiation fields were based on passive scattered techniques, where basically with the use of metal apertures and acrylic blockers, it would create radiation plans such as this, where certainly the highest doses were on the clinical target volume, but there would be a lot of spillage into the surrounding structures. And the radiation toxicities that you see in some of these patients, where these are high-grade sarcomas that tend to be anatomically extensive, so the fields are large, and relative to other cancers, what we know from sarcomas at other sites is that they tend to require higher doses of radiation therapy. While those high doses of radiation therapy could be delivered, some of the radiation toxicities we used to see were horrendous. And that would include, for example, brainstem necrosis, mesial temporal lobe necrosis, velopharyngeal insufficiency, hearing loss. And the complications were almost sometimes just as bad as the original disease process. But when you look, for example, at proton beam therapy with the use of pencil beam scanning, where the analogy is basically using a small pristine proton beam that's magnetically scanned over the distal aspects of the radiation plans, that spillage is a little bit less. And, the impact of this has been reviewed looking at complications and showing a reduction in radiation-induced complications that require hospitalization rates. And so I think these advancements have occurred across the board, across all radiation modalities. And so the concern that I think a lot of senior surgeons used to have about radiating these large tumors have been mitigated over time, and this has resulted in improved outcomes. The other area where we're seeing advancements is management of recurrent disease. When we looked at NCCN guidelines, there's a growing body of literature in terms of how to manage some of this newly diagnosed, but then this is the patient that I think we often deal with, the patient who's had 4 prior operations for their chondrosarcoma and who's failed proton therapy. And the expectation for a patient like this is that they would have undergone 5 or 6 operations, and really with no data demonstrating that there's any impact to retreatment or what the best treatment strategy is. And so this is the other area that's certainly advanced in the management of bony sarcomas. And we included some of our data as an example, but numerous other groups have looked at this, and we've demonstrated that there are a percentage of these patients or certain subset of these recurrent tumors where you can salvage them and basically provide them a disease-specific survival and a progression-free survival as if they were newly diagnosed and had never recurred. Again, we know that histology matters. So these bony sarcomas, some of them that are more indolent, are amenable to that big reoperation. And just as important as being able to reoperate on them is the ability to reirradiate them. Certainly, there's a lot of data with regards to radiation for newly diagnosed bony sarcomas. Just in general, for skull-based malignancies, there's a growing body of literature looking at repeat radiation for patients that have failed original radiation therapy. And certainly in our own practice, this is where we favor the use of SRS and have demonstrated this to be impactful for recurrent chordomas. And so for some of these patients that had failed previous surgery and previous high doses of radiation therapy, there is a glimmer of hope with regards to us developing newer treatment strategies for this. And so taking this all together, really what the point of the manuscript was that despite the original pessimism of the poor survival for these patients in the skull base, there are incremental advancements that have occurred with regards to pathology, systemic therapy, radiation therapy, our understanding of the biology of the disease, and of course surgery that I think are redefining expectations. And so I think, there's a lot of interesting opportunities up ahead. So that's sort of what I had to, review from the manuscript, and certainly happy to, spur on any discussion or hear everybody's thoughts.
Shaan, great work. Thank you so much. Very, very comprehensive, big review, obviously, and a lot of different things that have, changed in recent times as we've gotten better, like you said, at, microsurgical resection techniques, radiation, immunotherapy. My initial question is really, what do you say to people who basically say, well, if radiation is getting so good, what's the need to resect at this point? Why don't we just radiate rather than be responsible for the deficit or, responsible for something that radiation can handle?
Yeah, that's a good point. I think that, brings a lot into, quality of life too, because that's playing an increasing role. And what I would say, and I think the radiation oncologists would agree with this, is that really good radiation is not a substitute for surgery in terms of local control. One, even in the midst of the use of radiation therapy, that slide I showed you about impact of resection, that's within the context of using radiation therapy. So even with good radiation, there's a difference in survival in terms of ability to achieve that radical resection. Now, when you look at radiation alone, and all the studies have been out there, specifically with chordomas and chondrosarcomas, one, their ability to impact tumor control is dependent on the volume of disease going into surgery, right? So the less tumor there is, the better off it is, and the location of that residual disease. So I think there always is a need for surgery, and there's a need for surgery to be maximized. Now, there are situations where the morbidity of surgery may be high. Take a high-grade osteosarcoma that involves the lower cranial nerves, right? Where you're not going to get a radical resection unless you incur lower cranial nerve deficit. So for those higher-grade malignancies, that's what we deem unresectable, and we go down the route of combined concurrent chemoradiation therapy. But for the more indolent type of tumors like the chordomas and chondrosarcomas, surgery still very much needs to be maximized. And of course, for the high-grade malignancies that are resectable, they still play a key role. And again, regardless of advancements in chemo and radiation therapy, the sentiment's still the same.
Yeah, great points. Great points.
Yeah, I want to call attention to the fact that Gautam Mehta, who I don't believe is on the call, but has joined us on multiple other tumor talks, helped to put this together and had the privilege of training down at MD Anderson as well. I was impressed. Some of the cases you showed were just phenomenal efforts. And I think that it speaks to the fact that you have a multidisciplinary approach to these cases. You're not deciding things in a vacuum. You're not just looking at what you can do as a skull-based neurosurgeon, but you're looking at the total approach to these patients. And I think that that's really as we look at that special issue that came out, it's that multidisciplinary approach that's imperative to complex skull-based malignancies, and it's not something that is done at all places, and certainly your group has done exceedingly well.
No, I appreciate it, and I agree with your comments. I think I think perhaps we all feel the same way, is that the landscape of systemic therapy and radiation therapy is changing so much, and even surgery. And we certainly spend a lot of time trying to master and develop new surgical techniques, but I think having a bunch of medical oncologists and radiation oncologists that are much smarter than us, it's helpful to have them on your team so you get a good sense of what they can achieve and what they can't achieve. And I think it's also important is having people that are very transparent about what they can really achieve with chemo and radiation therapy too. I think that's helpful with the surgical decision making.
Yeah, and I guess it raises a good question. I mean, there are some discussions in meningioma literature and the glioblastoma literature. Is your goal ever to get a certain volume, down to a certain volume, or are you really just trying to get as much as you safely can whenever possible?
Yeah, so I guess what I would say is our goal is to get a gross total resection with negative margins and a neurologically intact patient. Now there are times, for example, where the cards may be stacked against you a little bit, right? Whether it's a previously radiated chordoma that's encasing the basilar artery, or a really calcified chondrosarcoma that's encasing the carotid artery. I say that we never go in with the intent of stopping short, that we always want to hit that home run, and to say that we've maximized surgery. And I think along the lines of not only to Randy's point earlier about, well, radiation's gone so good, then why maximize, or, can we shortchange surgery and make it a little bit safer? We've also looked at performance status outcomes. We didn't review that in the manuscript, but we have several manuscripts coming out and looking at that. Getting a gross total resection, actually, those patients do much better than doing a subtotal resection. And the reason why is that by maximizing surgery and with the right techniques, you should be able to get a neurologically intact patient or someone who's not as impaired. Their treatment burden is much less because the radiation dose can be scaled back a little bit. The radiation toxicity they feel is a little bit less. The need for systemic therapy may go away if you hit the home run with surgery. And so that what happens after surgery is dramatically different from surgery. So that we, again, I guess we've always gone with the mindset of trying to hit the home run unless there's clearly something that's going to make surgery unfavorable.
And presumably you're doing intraoperative neuromonitoring on a lot of these cases, if not all of these cases. Are you also doing intraoperative imaging at times, or you what is your treatment paradigm in MD Anderson for some of these cases? Are you doing intraoperative CT or MR, or is that not necessarily necessary? Just it's preoperative imaging and good neuroanatomic approaches and dissection off preoperative neuronavigation.
Absolutely. So definitely intraop monitoring plays a big role. And then really during surgery, it's really an anatomic dissection. So the philosophy we go in with is that, with the clival resection, we're going to go carotid to carotid, right? And navigation is not going to play a huge role. Same thing with the lateral skull-based approaches is that you're going to find normal anatomic landmarks that are going to serve as your margins for these cases.
Right. Gotcha.
Yeah, it makes a ton of sense. We have a question from Dr. Katua.
Right. Yeah.
He wanted to know how many were pediatric patients, and do you see any difference in the surgical challenges in the pediatric group versus adults?
Yeah, I think that's an excellent question, and dovetails on what we talked about in Tumor Talk last week, because there are some interesting challenges there.
Yeah, so I would have to go back and review exactly what percent. I would say, when we look at the sarcoma experience that we have, I would say maybe 10 to 15% are pediatric sarcomas. Certainly the sarcomas tend to be much more of an issue with the peds patients as opposed to some of the other sort of soft tissue malignancies. In terms of the surgical challenge there are several unique challenges. So first of all, from the surgery standpoint, the reconstruction can often be much more challenging. So, you really need a good plastic surgeon on board who understands some of the challenges with regards to free flap reconstruction with these lateral skull-based resections in the peds population. The vessels are smaller. Theoretically, the risk of post-op free tissue transfer failure is a little bit higher. With the endoscopic approaches, a lot of it's understanding the development of the skull base. Especially with patients that are less than 6, their sinuses aren't well pneumatized. And so if you're having to drill the carotids out in a complete block of bone with no landmarks whatsoever, it just requires an understanding of that anatomy also, and then also the reconstruction. And then there's a radiation side of things too. I have to admit, I'm not a radiation oncologist, so I'm not going to go too much into that. But, you do worry about the neurocognitive side effects. You do worry about the risk of radiation-induced malignancy in the pediatric population. I've treated several patients that have overcome their original malignancy, but are now dealing with the radiation-induced tumor. And same thing with the systemic therapy side of things that I think the medical oncologist will attest to. So definitely a very unique subset of patients.
Absolutely. Well, you know, this reminds me sort of it's going to sound goofy, but Jurassic Park, when Jeff Goldblum kind of criticizes people, and he was just like, you know, we spent so much time wondering if we could, no one stopped to think if we should. And I think that your paper, you know, you kind of demonstrate that we should, right? The results are getting better. You know, we're able to prolong life and progression-free survival, and, you know, less deficits in these patients. And so, you know, very commendable work. I really appreciate you being on. We try to limit it to about 30 minutes, and we're approaching our final point here. Any last questions, Dr. Sheehan, Dr. Nitesh?
Just real quick, you know, I know Dr. Sheehan touched on this earlier about the multidisciplinary approach, and, you know, sort of how do you counsel these patients? I mean, you know, they're going to go through a complex procedure, and, you know, obviously the goal is to get out as much as you can. And it always comes a risk, of course. But when you're seeing them in the office, et cetera, how do you counsel? How do you prepare them for saying that, all right, post-operative, you may look like this, but, you know, long term you'll get better, or you'll have a neurologically intact outcome long term. How do you prepare them for that?
Yeah, absolutely. So, you know, I think, you know, the way I sort of structure the conversation with these patients is really, you know, what their desire and what our desire is to get out of treatment, right? So survival, tumor control, and quality of life, and all are equally important. And I think having a frank conversation about, you know, what things are going to look like 6 months after surgery, and then as a recovering beginning adjuvant therapy, things look like 3 months, 6 months out. And depending on the site within the skull base, we do have an extensive conversation about some of the additional therapies that may be needed, such as speech therapy, you know, or, you know, there's also a psychology support group that we have for patients that need an oropectomy done, for example. Mm-hmm. And I think the other aspect that's helped a lot is that it's one thing for a physician to talk about what post-op recovery will look like, but support groups have been another sort of extremely important resource in counseling patients. So I openly, you know, encourage my patients to join those support groups out there so that they hear other patients' perspective on what things were like as they went through proton therapy and afterwards too.
Yeah, it's a tough conversation, right? I mean, it's you know, it's balancing a deficit, or it's balancing, you know, kind of disfigurement versus life, and it's a hard thing, I think, for, you know, patients to consider, and families in particular. Families always want, you know, the full thing, and they don't really fully get it until it's done, you know. But it sounds like the plastic surgery reconstructions have gotten significantly better, and that's very useful. And I mean, I'm sure contributing to better outcomes as well. So
absolutely, and I think also the ability as a surgeon to say, you know what, surgery shouldn't be done. You know, I do have those conversations also, right? Depending on how old the patient is, what their quality of life expectations are, and depending on the disease process, right?
Yeah.
Is that if we're not going to hit the home run with surgery, and there are alternative therapies that might provide that quality of life and similar survival benefit, then that's the way to go if we're not going to hit that home run with surgery.
So are you a member of any sort of consortium for these? I mean, these are obviously rare tumors, right? And you guys happen to be a little known cancer center somewhere in the US, but no, I'm just curious, because even so, these are rare things. And so do you collaborate with other groups to determine, you know, work on tissue diagnosis and treatment for these, and lab, you know, and basic science lab work and everything?
Yeah, that's a good point. I think that's been one of the shortcomings that we're actively working on, is partnering with other high volume skull base and spine centers. Even internally within MD Anderson, you know, our spinal oncology group with Larry Rines and Claudia Tatsui have a very robust program with the exact same diagnoses. So the approach we've taken is that forget skull base versus spine. We're just going to look across all sites, and the institutions put resources behind that. So we're applying that to a lot of our other sort of colleagues around the country and around the world.
Yeah, make it more of a pathology-based kind of a collaboration versus, you know, top of the head or bottom of the neck.
Absolutely. You're right. That's what needs to happen next, as opposed to these single institution studies coming out.
Yeah. Well, fantastic work again. I really appreciate you being on.
I appreciate you guys having me on.
Fabulous work, and you know, truly insightful. I'm impressed, and clearly the the best is yet to come in terms of the opportunities to manage these patients with even more refined approaches. So great work, and thanks so much for contributing to the special issue as well as Tumor Talk.
No, thank you, and congratulations on a great series. Honestly, I watch this, over a cup of coffee or lunch every once in a while. So thank you for you doing this for everybody.
Plug to your residents and fellows. We're glad you're able to join us.
Absolutely.
Yeah, and again, one last thank you to Stryker again for their contribution to the NREF and research. It's been really beneficial working with some of these groups. So thanks a lot.
Thank you.
Thanks.
Take care.
Bye-bye.